Hi, welcome everyone. I'm Davidicus Wong, family doctor at Burnaby for 3 decades and more with Leona Cullen from Burnaby Division of Family Practice. So this is this evening's edition of our Empowering Patients program, where we try to share useful public health information with everyone in our community. And this is a topic that's really near and dear to me because really at the core of what we do in medicine, trying to do the best for the individual patient, and it's guided by um, professional and personal ethics as well. Medical ethics sounds like it's an academic exercise or philosophy, but as you'll see, it's relevant to everything you do with healthcare providers, doctors, nurses, allied healthcare professionals, pharmacists. Every contact regarding your health involves medical ethics. So I'm going to guide you through the principles of ethics, and we'll talk particularly about some important issues like degrees of intervention. How do you make your wishes known in the future when you may not be able to speak for yourself? And we'll talk a bit about MAID as well, medical assistance in dying, and some of the rules and regulations and what it was designed for, and some updates over the next year. So I would like to invite Leona just to update you on key resources through the Burnaby Division of Family Practice.
Hi, good evening, Dr. Wong, and good evening, everyone. Thank you so much for joining us tonight. I'm very pleased to share some resources. If you've been here before, the chances are you've seen some of these. However, we've transitioned all of our resources over to our brand new Burnaby Division of Family Practice website, which is very exciting. It looks beautiful. It's easy to move around in. So the first link that I'll pop in the chat is the Empowering Patients main page. So that has all of our upcoming talks and ways to register. It has videos or recordings of previous talks. So if you've missed one and you're interested in the subject matter, check it out. And then it's got information, so information sheets and Dr. Wong's presentations. We share those as well because you can print them, you can download them, you can share them with your friends if you think they would be of value. I'm also going to share a link to the patient attachment page, which is essentially if you are needing a family doctor, as many folks are, there's ways of getting yourself onto the provincial wait list. The Health Connect Registry is what it's called. And if you live in Burnaby, then our team will, when your name comes up on the list, will reach out to you and get you attached. Then I'm going to share the Burnaby PCN or Primary Care Networks website with you. And that's our collaborative work that we've done here for the past 6 or 7 years in Burnaby in partnership with the Burnaby Division, the Fraser Health Authority, and community partners. And so there's many resources. There's health supports. So our urgent care centers fit into the primary care network. So there's lots of information on those. And then there's social supports, and those are that includes a full community resource directory. So if many topics, but children and family resources, developmental disability resources, food and meal supports, and supports for seniors, just to name a handful of them, but there's many more. So check that out. And then there's a new page on the website that just launched, and that is our own Dr. Davidicus Wong, who's been writing the HealthWise column for I don't know how many years, Dr. Wong. Many, we'll say.
34 years.
34 years. And so unfortunately, and that's where in our local papers, the Burnaby Now, the New West paper, which have unfortunately have shut down. But we decided we didn't want that good resource to go to waste. So we've recruited Dr. Wong to continue writing his articles, and they'll be shared on the PCN website. So I'm going to share a link to that. So I think we may hear from you once a month-ish
Yes.
for articles. So yeah, be sure to favorite that page. Another page is the checkup. So that's a public health newsletter, for lack of a better word. You can sign up. It comes out monthly, and it includes information on public health, community events, and many other things. So if you want to just do a little bit of reading about what's going on in health and well-being, another little read, you can sign up for the checkup. And I will pitch. It's actually only 2 weeks away, just because of scheduling. In 2 weeks, we're hosting another empowering patient talk like this, on the positive potential of our relationship. So that's a really good one. So 2 weeks from today, 7 o'clock, we'll be here. So I'll put the link in there for you to register so you don't miss out on that one. And if you have any questions for Dr. Wong, please feel free to pop them into the chat, or there's the Q&A section. Either way, I'll just make sure Dr. Wong can address them at the end. And at the very end, when we turn off this, when we pause the webinar, there will be an evaluation with 8 questions this time. And just your honest feedback really helps Dr. Wong and I as we continue to evolve the program. So that's it. That's my spiel. Watch for the links in the chat, and please let me know if you have any questions.
Great. Thanks, Leona. And thanks, Leona, for all your work with me over the past 10 years in the Evolving Empowering Patients program. So we used to do this all in person, but since the pandemic, we've been doing it online. And I think it's great because we can reach to more people and fit more people in a room than we can in the library or the community center. So we are here to express our circle of caring that family doctors, all doctors care about our patients, but we also care about our community. And that's a big part of the Burnaby Division of Family Practice. It's an association, a nonprofit of all the doctors that serve the Burnaby community, um, and whether or not they be our personal patients or not. And I'm one of the founding physicians many years ago, and still remain actively involved in our Burnaby division. And together, we also care about our future health of everyone in our community. So again, we care about our patients and we care about our community. So today I'll talk about what we all should know about medical ethics, why ethics matters, and understanding ethical principles and how they apply to everyday interactions with healthcare providers and how you make decisions about your own health. And I'll talk about like preventive health, preventive bioethics. So you'll get a better understanding as we go through. But first, I'd like to start with a little quiz. You don't have to speak out, but maybe just answer it in your own mind. So first question is, bioethics relates to choice one is telling the truth in celebrity biographies, or does bioethics relate to treating animals humanely, or does it relate to medical ethics? So you probably guessed it's medical ethics. Medical ethics is the application of ethical principles to healthcare. And the four big principles of bioethics or medical ethics, which I'll go in detail a little bit later. Number one is the first rule of medicine, do no harm. The complicated term is non-maleficence. So do no harm is the number one rule. Beneficence, of course, is to do good. That's why most of us signed up to be doctors, because we want to help people. The third principle is autonomy, respect for an individual patient's choices. The fourth is justice, to be fair and to treat like cases alike, so no one gets special treatment. I've mentioned in previous talks about the doctor-patient relationship that the motto for my practice that my medical office assistants and staff see on their side of that reception counter is treat every patient like you would like a family member or best friend treated, like the same level of care, the same attention, and the same compassion. And finally, confidentiality, respecting personal information. And I'll explain the reasons why that's so important in the doctor-patient relationship. So applying those principles. So dilemmas always arise in cases where those principles kind of conflict. For example, respecting an individual's autonomy, their right to make their own decisions when they are at risk for harming themselves or others. So it's a delicate balance because we don't want someone to harm themselves. And a treatment is considered appropriate if the potential benefits outweigh the potential burdens or the risks or the harms that are related to it. So it's a careful, nuanced decision about what treatment. And the same treatment for the same condition may not be appropriate depending on the patient's values and their particular circumstances. Life support, like cardiopulmonary resuscitation, artificial feeding, like with feeding tubes, or external ventilation, or being on a ventilator. They're appropriate if they provide an acceptable quality of life. And that quality of life is best judged from the perspective of the individual patient. So that if you're able to speak for yourself, you can say whether or not you want a particular treatment. But if you are unable to make your voices heard, it's important that we do that preventive part in expressing our wishes and to make sure that we have people that can make decisions for us, like a trusted family member or a spouse that will respect your individual wishes. So it requires a lot of conversation, even when we're all feeling well, just to prevent problems or dilemmas in the future or difficulties in family members making decisions if you can't speak for yourself. Question number 2, true or false? Bioethics has more to do with philosophy than with day-to-day work of healthcare. Well, as I already said, that's false. Medical ethics is really the foundation of medicine. Our tests and treatments are merely tools, and ethics guides us in their appropriate use. It really gets to our values, so what we're trying to achieve for that individual patient. Question number 3, autonomy. So is it A, the economics of the automobile industry, or is it a Tomorrowland attraction in Disneyland where kids get to drive futuristic cars oddly powered by gasoline engines, which my kids love to do? Or is it C, the ability to make independent decisions? And I bet you guessed right. Autonomy is the ability to make independent decisions. And question number 4, the single greatest threat to your autonomy is A, the healthcare system, B, Big Brother, C, doctors and nurses, or D, your family. Is D. If you're in a condition such that you weren't able to direct your own care for whatever reasons, such as if you had a stroke or you're unconscious and you couldn't speak for yourself, and if you had not made it clear in advance what your preferences would be, like if you would want particular treatments or not want those treatments, then family members often come into conflict with one another, or they might decide what they would want rather than what you would want. So it's important to have those conversations well in advance when we're healthy. And also to make sure that you know that the person you'll choose to be your substitute decision maker, if they are needed, are going to respect your choices and know what your values are. So this was a common problem that came up when I was the chair of the ethics committee at Burnaby Hospital for 15 years. I consulted on numerous cases, often patients that came in through the emergency with a stroke, people at the end of life, people that were on life support, and family members or the healthcare team had conflicting ideas of whether or not certain treatments should be continued or not. So it's best to have these conversations ahead of time so that you know someone will be able to speak for you with your voice. And the final question, true or false? Most ethical dilemmas are unavoidable. False. So with proactive reflection and discussion, you can make your choices clear. It'll make things so much easier in the future. So ethics really does matter. So a lot of people think it's abstract philosophy for students, academics, and older people. But really, it's like thinking about the meaning of life. Most people don't reflect on the meaning of life, their values, or their life's purpose unless a crisis arises or they reach a crossroads like midlife or loss of a loved one, losing a job, or the end of life. You could think of the values of ethics as using a map or a road trip rather than being guided by GPS, which might lead you and get you distracted on numerous detours with accidents and breakdowns and other drivers that you're traveling with. So without that big map and looking at our values and know where we really want to go, we might find ourselves lost and far from our destination. And of course, some of us, at least half of us, don't really like to ask for directions. So again, why ethics matter? Everyday ethics. So ethics applies to every time you interact with a healthcare provider, even if you don't realize it. For example, When we're talking about confidentiality of your personal information in the doctor's office, a common situation that can arise just in the family practice offices, a mother might ask if her daughter came in earlier today and wonder what she discussed with the doctor. So if it's like a teenager that's able to make her or his own decisions, we do wish to maintain their confidentiality as well. And we make that clear with the child. And as kids get older, we make it clear to the parents as well that we want to respect that individual's confidentiality. Of course, there are some exceptions to confidentiality that we'll discuss in a few minutes. Another example, a concerned family member might call and ask about the details of a patient's medical condition. So unless we have the permission of the actual patient, we're not supposed to be discussing those details with the family member. Of course, it's a bit different if it's a parent and a 5-year-old child. Of course, we have permission because they're the guardian and they're making medical decisions on behalf of that child. When we're talking about informed consent, like having enough information to make a decision. So any test or intervention, including a simple blood test, cannot be ordered without your clear consent. So that's the case. So if I'm talking to a patient about blood tests, I actually go through what we're actually testing so that there won't be things added on that the patient doesn't give express permission to test. Like I wouldn't test for some infectious diseases like HIV, unless the patient expressly said that they wanted to test for that. We need their permission. Things get a little bit fuzzy in the hospital where numerous tests are actually ordered and you don't really know what those tests are. So I would hope that doctors in the hospital, if they are able um, to speak to the patient, inform them of the reasons for testing particular things so that you still have a choice to accept or decline any particular test. And informed consent really requires us as healthcare providers to provide you with the key information that you need to make decisions about that treatment. So again, let's go through each of those principles. First, beneficence, to do good. The primary goal of medicine is to help the individual patient. That's why we all signed up and went to school for so long. And that's the goal of every patient that we meet, doing our best to look after their needs, not our own personal needs. And the most important rule, what we call the first rule of medicine, is to do no harm. Above all else, do no harm. So that's been the case since the days of Hippocrates. Primum non nocere. Above all else, do no harm. So justice reflects just treating people fairly, giving the same level of treatment to everyone, regardless of their background, their personal status, whether or not they're easy to get along with or not easy to get along with. We want to be fair and give the best care to every individual and respect their autonomy. So as I mentioned, my personal golden rule of medicine is to treat every patient with the same care and consideration I would want for a best friend and a family member. Confidentiality, respecting the individual patient's private information. So that is so important because if you weren't sure that I'm going to keep your personal information confidential, then you may not share really important information, but information you wouldn't want to share with other people. So we do our best to be non-judgmental and accept the patients and know that we're all have a variety of different things that we don't want to share with other people, including our own family members or friends. So it's so important that you know that we will keep things confidential. And again, there's very few exceptions to this that we will discuss. So there is one exception, such as the duty to protect, when you as a patient pose a serious threat to others. For example, if you express intent to harm or to kill somebody else, we have a moral duty and a legal duty to protect you, either to contact the police if we had to, or to contact the individual who's at risk. And there's a duty to report unsafe drivers. So even though I care and love all my patients, there sometimes are points where they're no longer safe to drive, either due to cognitive abilities or physical abilities, where they're at risk of harming themselves and other people by getting behind the wheel. So we are morally obligated to actually report that to the motor vehicle, or to speak to family as well, just to ensure that unsafe drivers are not at risk to themselves and others. Issues of child protection. So if we have evidence or a strong reason to believe that a child is endangered due to abuse or other problems or risks, then we have a duty to report that to the uh, Ministry of Social Services. And certain infectious diseases are automatically reportable. For example, if we're doing tests for chlamydia and gonorrhea and they become positive, the health department automatically, regardless of what the doctor writes on the lab requisition, it's reported to provincial health services, and then they contact us to make sure that we're connecting and following up on contacts to make sure that the infection is not spread to other people. So usually that means a form so that um, we can indicate whether or not we want the health department to follow up with the individual, or we would just speak to the patient and tell them that you need to inform your partners so that they can get treatment and testing as well. And another thing that's often reported just to the health department, which most people don't worry too much about, if a patient comes in with bad diarrhea, we suspect food poisoning, for example, because that could be from a public risk. Not that you're going to infect other people, but if you got it from a particular restaurant, usually public health wants to follow up and check on contacts. So if you are diagnosed, for example, with gastroenteritis or food poisoning from E. coli or Salmonella, even before the doctor might get a chance to talk to you about it, then often public health will contact the individual and just ask, what restaurants have you been to? And just so that they can make sure that there aren't unsafe practices that put other people at risk unrelated to you. And another exception would be a court order. So if the court says that they give us an order that we have to turn over records, which is not too common, then we are obligated to do so. That's often the course. Usually it's often a legal case and the individual patient often has already given consent. So the patient is usually aware of that as well. And we would let you know that we've received the court order so that you would know as well. However, if police officers just came into the office, they did not have any orders or any warrants to have access to the record. We will not release records to them unless we have that court order. And of course, minors like young children, babies, and others who rely on others to provide consent, then we share that information with the guardian. So you might wonder who has access to your records. So of course, your physician and the other physicians that are part of the professional staff. So my medical office assistants do have access to the records, but they know they're not going to be looking at confidential conversations and things from our clinical notes. But of course, they're helping us sending off the referral letters that we're sending to specialists or to other physicians. Um, so they have access to the information. Third parties like insurance companies, like ICBC, if you had a car accident, you usually sign a consent form to provide that information. And lawyers, like your own lawyers, if you're in a court case and they request that information with your consent, it has to be with that written consent or with a court order as well. And of course, other healthcare providers who are involved in your care, such as your hospital team, the specialists that we might refer you to, they have limited access to the information that we send to them. So, so there's more people that look at your records than just your physician, but we do everything we can to make sure only that is essential and important and that you have awareness of that as well. However, I'm in an office with 12 other doctors, and some of my sister actually had is seeing one of my colleagues, but I will not look at her chart because I know that would be a breach of confidentiality. I also have a cousin that is seeing one of my colleagues, and I let him know that I would not be looking at his chart because I have no business to look at his chart. Otherwise, he wouldn't know what he could share with my colleague as well. However, if he asks me to look at a particular test result on his behalf, and if I have his permission, that's the only case where I would do so. And autonomy, again, is the right of the capable individual to direct his or her own health care. And you also have the right to refuse any treatment. However, you don't have the right to demand treatment that is not appropriate or not available, like just things that are not um, medically, by medical consensus, not helpful for that condition. And that includes some tests that are not appropriate for your condition too. So when we're getting back to informed consent, there are two big keys. One is that we provide enough relevant information for you to make a decision. And we'll talk about what kind of information that should be. And the individual has to be capable of understanding that information and making an informed decision. So sometimes in the cases of dementia or delirium, where you're temporarily confused and not thinking clearly due to illness, for example, you might not be capable of understanding that information. So we have to rely on a substitute decision maker. Often it's the next of kin, but it could be whomever you may have appointed. And that type of information you need to make a decision is about the benefits, the risks, and the alternatives of a test procedure or a drug. So you need to know that information before you choose or refuse it. So that applies to all medications as well. And also invest some treatments, such as particular investigations like a colonoscopy, where we put a scope up the rectum to look for any tumors or polyps or inflammation. It's really important that we talk about the benefits, why you might want to do this test, what information would be gleaned from it, or how your health would be improved by it, but also the risks, the common risks, and also even the rare but serious risks that you would want to know about in advance. And also if there's alternatives to a particular test or procedure that you could choose that might be reasonable. We talk about the risks and benefits of those alternatives as well. So due to illness and incapacity, you may not be able to give informed consent. So who will decide on your behalf? So this came up, as I mentioned, frequently when I was chairing the ethics committee at Burnaby Hospital. So we consulted on a variety of ethical dilemmas faced by patients, their families, and the healthcare teams. And all of the patients at those times, in those cases, were no longer capable of independent medical decision making. Either they were unconscious or had severe dementia or suffering from a stroke to an extent that they weren't able to make their decisions known. Um, and in those cases where it wasn't clear what the patient would have chosen, and often family members and healthcare providers might be in conflict. So siblings from different parts of the country might come in for a consultation together with the healthcare team and my ethics team. And then we try to work through and make a decision based on the individual patient's values. So John Milton, author of Paradise Lost, wrote, "The road to hell is paved with good intentions." And I could be quoted as saying the road to ICU is paved with clinical practice guidelines. So it's a bit tongue in cheek, but it means that our treatments and tests in medicine are tools of medicine. So we do have clinical practice guidelines that say that for this condition, this is the standard of treatment, or this what is what should be offered. But ethics, which looks at the values of the individual patient, will guide us in the appropriate use of these medical treatments. So they're just tools, but they're supposed to be used in the service of the individual to respect their autonomy, their values, and their best interests. So in these consultations, which usually took an hour or two, we would have the whole healthcare team. We would have the family members, the people that are involved in the decision making, and then we'd step back to see the whole patient, their background, their religious beliefs, their personal beliefs, and the social factors involved, not just the medical facts. And when we have this full whole person view, it's much easier to come to a decision, a consensus decision. So the medical facts would include the past medical history of the individual, their current medical situation, including the diagnosis and the prognosis, what is expected with this condition, and also looking at each of the treatment options, whether that might be starting or discontinuing artificial feeding through a feeding tube, or starting or discontinuing ventilation. We talk about the risks and benefits. But when we look at the personal factors, so we can really only glean from the friends and families of the individual, we ask about the personal preference of that individual. What are their values? What are their religious and cultural beliefs? Where do they have a sense of meaning and quality in their life? And what does quality of life mean from the perspective of the individual? Because everyone would judge a situation differently based on their values. We'd ask about if they had this conversation in the past at family gatherings or when they had a friend that was in a similar situation, did they voice what they would have chosen for themselves? So those deeper conversations, personal conversations are so important so that we can really look at what the patient would have decided for themselves. It is so helpful that people already have completed advanced medical directives. And we'll talk at length about that, about the details of how you can express your desires in the future in case you couldn't decide for yourself and how to make your wishes known. And the social factors include the personal views of friends and family and anyone else that would be affected by decisions that we make together. I'll talk about medical assistance in dying. So this is MAID, so relatively new in Canada. Um, so here are some of the rules about medical assistance in dying. Um, Generally, visitors to Canada are not eligible for medical assistance in dying. Someone has to be at least 18 years of age and mentally competent. That means capable of making healthcare decisions for themselves. And they must be suffering from a grievous and irremediable medical condition. So a condition that we cannot cure and is causing significant suffering. The individual has to make a voluntary request for medical assistance in dying, and it's not the result of outside pressure from other people. And they must be able to give informed consent to receive medical assistance in dying. So again, you must have in order to apply. So this grievous and irremediable condition would be a serious illness, disease, or disability. And up until March 2027, this excludes mental illness as the sole reason for medical assistance in dying. So it's going to change after March 2027. The individual must be in an advanced state of decline that cannot be reversed, not curable or improved. And the experience must be unbearable either physically or mentally from that illness, disease, or disability or a state of decline. And it cannot be relieved under conditions that you as an individual consider acceptable. So you do have a right to refuse treatments such as chemotherapy or radiation for cancer, for example, like for metastatic cancer that is causing a great deal of suffering. It does not need to be a fatal or terminal condition to be eligible for medical assistance in dying, because some people may be suffering from progressive neurological conditions that will eventually take away their ability to be independent, or they're already dependent on other people. And it is causing suffering to quality of life from that individual's perspective. So people can make the decision, even though they may not be dying in the foreseeable future, that there might be years, but they're expected to decline and have further suffering. So an individual in that case would be eligible to apply for medical assistance in dying. And of course, informed consent means that to be eligible, you must be provided with all the information that you need. This means you've consented, given permission after you have received all of the information, such as your diagnosis, all the available forms of treatment, and available options to relieve suffering, including palliative care. And you must be able to give informed consent at the time of your request and immediately before medical assistance in dying is provided, with the exception of special circumstances. That's called the waiver of final consent. That means you have a right to change your mind at any time, that you can withdraw your consent right up to the very moment. Even if you plan made for a particular date and that day comes up, you have a right and ability to reverse and change your mind. So this waiver of final consent um, allows you to waive that requirement of changing your mind before MAID is provided if these conditions, a natural death is reasonably foreseen, and you make the decision while you do have decision-making capacity. So you've been assessed and approved to receive medical assistance in dying. The practitioner advised you um, that you're at risk of losing capacity to provide final consent. For example, declining cognition, progressive neurological conditions that might prevent you from expressing a change of mind. And you've had made a written arrangement with your practitioner in which you consent in advance to receive MAID on your chosen date if you no longer have the capacity to consent on that date. So it's important to be able to make decision and to have the assessment done while you're still able to make the decision. So originally, we had expected that in 2024, that the eligibility criteria for medical assistance in dying would include um, mental illness, like solely mental illness. But this has been delayed at least until March 2027. And this is to allow um, every province to make sure that safeguards are in place and that they have the ability to make proper assessments. So things may change a little bit more than a year from now. So we'll hear more about that when that rolls out. And then again, waiver of final consent that we covered. Any arrangement for the waiver of final consent will be considered invalid if at the time of that MAID is provided, you no longer have capacity and you demonstrate refusal or resistance. So if by words or sounds or gestures, um, uh, then that final consent will be considered invalid for that waiver. So um, some reflexes and things are involuntary, but if it's felt that you're expressing in other ways that you have changed your mind, then that would be invalidate the waiver of final consent. So again, preventive bioethics, Jesus said the kingdom of heaven is everywhere, but men do not see it. And of course, I said when I was teaching ethics to our hospital, ethics is everywhere, but we just don't see it. Um, so these issues are around all of us, but it's best if we think about it in advance. So talking about preventive bioethics, like preventive medicine, I'd like you to anticipate the future when you may be capable and might be suffering from a serious illness. It's important that you understand the benefits and burdens of interventions such as artificial feeding tubes, artificial ventilation for breathing, and cardiopulmonary resuscitation. So it's good to talk about these things in advance or to research them in advance as well. It's important to consider what gives your life meaning and what constitutes a good quality of life. I've had patients in a number of group homes who have had brain injuries or other conditions that take away their ability to live independently. But a lot of these kids, and then now young adults do still enjoy a good quality of life in spite of those limitations that those of us that are able-bodied might not appreciate or enjoy in the same way. So it's important to look at quality of life from the perspective of that individual. Do they have a good capacity for enjoyment of food, of company of other people, of enjoyable experiences, and um, and how much suffering that they're experiencing from their own perspective. It's important to communicate your values and your wishes while you can. So ensure your family knows what you would want in different circumstances. So advance directives are usually what we put into writing, a statement of what your preferences for medical care, um, and that you want this to be referred to when you're unable to make your own decision. So what procedures do you want, and what procedures would you refuse? And under what conditions would you want or refuse those particular treatments? And who do you choose to be your substitute decision maker if you weren't be able to make decisions yourself in those circumstances? For example, you may not wish to have CPR, which is the chest compressions, assisted breathing, intubation with a tube down your throat to assist with breathing, or electric shocks or defibrillation if you had an irreversible terminal condition, such as terminal cancer, and if you had no hope of return to an acceptable quality of life from your perspective. So that would be a reasonable decision to make that known that you wouldn't want CPR under those circumstances. And you may not wish to be on mechanical life support if you are in a persistent vegetative state with no hope of recovery. Because if you don't make those wishes expressed to your loved ones, actually either verbally or even better in writing, sometimes you'll end up on life support. And then it's a really tough decision for family members and the healthcare team to decide at what point would you stop those life support measures. So we should always plan in advance, of course. Talk it over with your family and friends and choose someone you would trust to respect your personal preferences. Again, if you have an advance directive, talk to your family doctor, inform your family doctor, and together you could put it in writing. So one really useful document that you can find online with all the health authorities is the My Voice document. It kind of walks you through thinking about the future, different circumstances, different procedures that you may or may not want to have in different circumstances. So you can kind of Google My Voice on advanced directives, and there's a PDF of a workbook that you can work through, and definitely connect with your family doctor if you need help going through this as well. Um, and then this is kind of tongue in cheek, but of course there's other simpler advanced directives, like if you're getting surgery on your right knee, I would put this on my left leg just to make sure when I'm unconscious and under anesthesia that they don't do the wrong knee. And of course, if you're going for a hernia, you can leave directions with your Sharpie as well that you're here for the hernia, you're not here for the vasectomy. This is a document. It's called the MOST document. So for many patients coming into the hospital, this is called the Medical Orders for Scope of Treatment. So it's completed by your healthcare providers in the hospital usually, but it's useful for you to look at this document in advance, especially if you're over 65 or if you have a chronic condition or you have some other serious medical conditions that would change what kind of procedures you would want under different circumstances. So it looks a little bit complicated, but I'll walk you through really slowly. So this is completed by healthcare professionals like the doctor that's treating you in the hospital, but it could be filled out in advance with your family doctor. And in BC, this can actually be sent to a central registry. Once you have a discussion with your doctor, family doctor can send that to the central registry so that the hospitals have access to that, no matter which hospital you might end up going to in acute illness or after an accident. And of course, this can be updated and changed at any time, but it's useful for you to kind of look at these things to consider it to start with. So the first thing you would want to know is whether or not you would want CPR. So if your heart stopped or if you stopped breathing, would you want CPR, like chest compressions, defibrillation with the paddles, or intubation? So if you're elderly, like if you're 80 years old, unless you're exceptionally healthy, like a 30-year-old, the likelihood of success with CPR is extremely low. The likelihood that you would be resuscitated and be able to come back to a meaningful life is actually very low. So many older people would decide they wouldn't want CPR for any reason because they're not likely to come back in good condition with full cognition and abilities. However, if you're 30 years old and healthy, you almost certainly would want CPR because you could just be getting electric shock and your heart stopped, and of course you'd want resuscitation. So it depends on your condition and your health, but also on your age too. So in all of these criteria, you decide whether or not you would want CPR. And if you decided not to have CPR, the question is, what level of care would you want to have in hospital or at home? So there's different levels. So uh, the first one you see CPR C2, that means you would accept being in an intensive care unit or a cardiac care unit. You would have CPR, you would allow intubation, you treat reversible conditions, you manage symptoms. However, you decided against CPR, you could still be treated in the ICU or the CCU, and you could decide whether or not you would want to have intubation for breathing. And site transfer means obviously if you're in a nursing home or long-term care or at care at home, you would be totally fine going to the hospital and even in the ICU or CCU. And we treat reversible conditions and we treat symptoms as well. If you did not want to be intubated on a breathing machine, then that would be level C1, where you can still go to critical care, but not getting CPR, not getting intubation, but you can be transferred to the highest level of care and treat all conditions that are reversible and manage symptoms. Uh, but some people would not want to be in the intensive care unit. And in that case, we still treat reversible conditions like infections or do surgery if you broke your hip or a broken bone that needs surgery, and we manage symptoms. But there are some people where, for example, you might be in a nursing home or getting care at home. You're not completely independent, um, but you want to remain at home or in palliative care. Um, if you're in palliative care and the end of your life is foreseeable, some people make the decision not to treat reversible conditions such as an infection, pneumonia, that you would still stay wherever you might be, either in hospice or palliative care or in the long-term care facility or at home, but we would manage symptoms such as pain or shortness of breath. And so it sounds a little bit complicated, but it's worthwhile, especially if you're over 65 or have chronic conditions such as heart disease, like ischemic heart disease or heart failure, or end-stage chronic lung disease, that you have these discussions with your physician and your family doctor can kind of guide you through completing this form. It's so much easier than waiting until you're in the hospital with acute illness and then being asked how to make these decisions. And you may not be able to make those decisions at that point, depending on your level of consciousness. So this form you don't need to sign, but it's signed with the doctor referring to discussions he has with you or your substitute decision maker. Again, these are the same things, just in close up. So I'd like you invite you to share what you've learned today, just with the people in your community and your loved ones. But we really want you to be kind of thinking ahead of what decisions you would like to make for yourself. And because these are very controversial topics, I've left a lot of time so we could answer all of your questions. because there's a lot of misunderstanding about medical assistance in dying, where I've had patients that are elderly, like in their 70s and 80s, and asking for MAID, although they don't actually have any medical conditions. They are not suffering from a grievous medical condition, but they're afraid they might have one in the future. So MAID is not actually intended for that because you actually have to have a grievous condition at that time that you're applying for it. So we have to talk about advanced directives in different ways for them. Okay, I'd like to turn things over to Leona so maybe I should turn off my share and then we
Then
can,
you can see peeps.
okay. Can you turn off my sharing so people
Let
don't
me
have
just
to
see.
look at my,
Let me see.
I could do it here.
There you go. All right. Yay. Excellent. Thank you so much for all that information. It was, I mean, it is a lot, but it's really important. So thank you for that. We did have a couple of questions. So this is earlier on in the consent section that you were talking about. Celine wants to know, what about when you are accompanying an elderly person to a medical appointment? So around that consent piece.
Yeah, so we're assuming that if the patient comes in, like if a friend or a family member is bringing an elderly patient, um, that it's okay to discuss things, their medical condition and problems in front of them and examine you in front of them. But I do ask permission that is it okay if your family member or your friend is here for the whole visit and we can discuss everything. So that's totally fine. If it's not clear to the healthcare provider, then they'll ask to make sure that you have permission to share information.
That's great. And there was another question. Forgive me, Celine. You have a question about people with Alzheimer's, but I'm unsure as to when that question popped up. So I've given you uh,
Oh,
the ability to ask Dr. Wong yourself.
oh, can you hear me?
Yeah,
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 Oh,
yeah.
thank you.
oh, when the Dr. Wong was discussing MAID,
Okay,
yeah, because there seems to be some conflicting information. It says that you have to have a irreversible condition, right? And that there's an imminent death. But then there's another section where you mentioned that you don't have to have that, so I wasn't too sure. Like
Oh, death,
Alzheimer's is sort of like that, right?
yeah, death does not have to be
Yeah,
imminent or in the foreseeable
right.
future.
Yeah. So
Yeah.
what if it's like, can I sign something um, for in case I get Alzheimer?
Yeah, so that's why a lot
Because
of
I
my
won't be able to do it if, when I get it, you know?
yeah, so MAID is not designed that way.
Oh,
So we can't do it before we have that condition.
hmm,
However, if so we want to you want to be thinking about that while you still have decision-making capability.
right.
Um, and that's the case where you can waiver the consent to um, that last minute refusal from aid if you have a
Hmm,
declining neurological condition such as dementia of any type, not just Alzheimer's dementia.
hmm,
So we'd want to catch it before it reached that point.
hmm,
Yeah, that's a difficult one because it could be very slow and gradual.
hmm,
And often people at the beginning they don't realize they have dementia.
right.
Most
But
of the
what about after you've been diagnosed though, and you're still capable of making the decision? You're not quite at that point yet.
Yeah, so that's that's a bit tricky because you have to be
Okay.
suffering from
Hmm,
grievous harm either mentally or psychologically or physically. So it's a tricky one. We still have to make sure you make the decision while you still have consent, but it has to be
hmm.
to the extent that we're treating everything that we can. Yeah, that's one of the things we all fear is that um, yeah, we can't choose how we're going to go first if our body's going to outlast our
Yeah,
cognitive function or if the cognitive function goes first.
right.
Yeah, it's quite a challenge with increasing
Hmm,
age of our population and more people being diagnosed with with dementia.
So currently, May doesn't really cover dementia then.
Um, in most cases, no, but I'm sure there's particular cases where there's progressive dementia and they're suffering from that, and the
Hmm.
person is still able to make that decision.
Mm.
So I think they should, if they're seriously considering that, they should, yeah, talk that over with their healthcare provider and look at their particular condition.
Okay.
Great. Thanks, Celine. Next question. What are your thoughts on extending MAID for mental illness? Should it be allowed? What guardrails do you want to see? Part two of that question. What would be the difference for you, particularly in the vulnerable and elderly population, between not wanting to live any longer, suicidal ideation, or maybe having eligibility for MAID?
Yeah, that first part, I'm, yeah, I'm torn with this because even when we were chairing the ethics committee, we had no idea that we would ever have medical assistance in dying. At that time, we were doing our consultations. We talked a lot about that because in the Netherlands, they had been doing it for many years already. But there hadn't been discussion at that time about having it in Canada. So it's a slippery slope. Even made, it's so important that the patient isn't under some duress or pressure from family members or others to for applying for medical assistance in dying. Also, I know because I do palliative care for patients, I know there's lots of things, there's plenty of things we can do to relieve pain and suffering. And we know that sometimes that might include having to increase narcotic medication to relieve that suffering, but it might lead to an earlier death, someone who is dying in palliative care already. And that was always considered to be ethical because it's with the patient's consent, it's treating, relieving suffering, although there could be side effects like respiratory depression and dying early with symptom management. So it was quite an emotional, psychological, and spiritual battle. And we know that that's a big ethical dilemma for a lot of healthcare providers. We can see the dilemma of the faith-based hospitals, Providence Healthcare, where it looks like they may be forced to provide MAID in their facilities. So physicians and nurses and doctors that when it's against their own personal principles about ending a life, that they may be forced to do that if they're legislated to do so. So that's very difficult. And for mental illness, we try so hard to alleviate suffering through counseling and support and medications. Um, but I wouldn't want is someone, because we do know that when we're really depressed, it really shades our thinking as well, and that we can only think of the negative. We're unable to see the positive. We lose hope. We don't think things are going to get better at any time. So for many people suffering from depression, that they could actually improve, but a person could refuse to take medication or not want to engage in counseling and mental health strategies. On the other hand, there there are a lot of people that have been through a very traumatic life, and and it doesn't matter how much counseling they get or what medications we might prescribe or the psychiatrist might prescribe, that they can never achieve the level of quality of life that they accept. So I can understand why people would want to end the suffering in those cases. Um, so I'm a bit torn because some people may not see the options, but for some people it may be very appropriate for them based on their own quality of life and their own circumstances. So yeah, it's very difficult. It's very difficult. So we're all kind of torn. And that's why there was that moratorium where it was postponed just to kind of prepare and try to create safeguards so that people aren't coerced to make the decision, that people are able to see clearly all their options before they choose medical assistance in dying. And then the second part of Craig's question was, what would be the difference for you, particularly in the vulnerable and elderly population, between not wanting to live longer, suicidal ideation, or maybe eligibility for MAID? So, Craig, did you mean that if someone is suicidal, would they be appropriate for medical assistance in dying?
Hello there, you can hear me?
Yeah, I can hear you,
Yeah.
Craig.
There we go. Hello, you two. Um, yeah, well, this came from my own personal experience with one of my parents that just didn't want to live. They lived a full life. But when you know the difference between that or they're thinking about, maybe throwing themselves off the porch in the hospital, or maybe the answer to them would be medical assistance in dying. Is there any signs or is there any, I guess, any indications on which one it is? If that makes any sense.
Yeah, you would need the assistance of a geriatric psychiatrist to see if this is from depression, if the suicidal thoughts are from depression. Um, but also the other options would be palliative care. So we really, um, the that elderly family member could decline treatment, and then we just provide palliative care. So if they, yeah, don't want any more interventions, want to stop all their medications, that they can if they're capable of making that decision. And then, but if they weren't able to express that or make that decision, then as a substitute decision maker, if it was your loved one, then you'd have to talk to the healthcare team about if palliative care would be more appropriate, where we manage the suffering that they have, any pain that they might have, um, and withdraw treatments that we feel is not appropriate for them with their wishes.
And would that be their wishes as they would be at the time, or maybe their wishes that they had if they were a 20-year younger version of them was standing in that room?
That's really hard because when we're 20 years old, because when I had a group of medical students about 20 years ago, and they were filling out advanced directives, and they said that if they had a stroke and they couldn't snowboard anymore, then they wouldn't want resuscitation. We didn't have MAID at that time,
Wow.
but but that's when you're
Couldn't
young and healthy,
snowboard
and
anymore.
yeah, and then you can't. But
Ah,
but I've
you.
also consulted on cases with the ethics consultation where the healthcare team said, "Oh, this patient has moderate to severe Alzheimer's dementia, and so we shouldn't be offering all these interventions, even though they want to have those interventions." So before actually doing the consultation with family and the healthcare members, I would go and visit the patient to actually see them. And I went to see this really happy, um, elderly lady. She was forgetful. She wouldn't be able to manage her own affairs, but she was still enjoying her food and she was still enjoying the flowers in her room. She was able to have a conversation. She seemed to be actually very happy. So in her case, it seemed, yeah, quite appropriate to give her treatment that would sustain this quality of life that seemed to be acceptable from her perspective.
Right.
And one thing
So,
I'll go ahead, Dave.
and I've seen some people with dementia who are, yeah, actually perfectly content and happy. They they cause a lot of work for the people around them, but they are happy and sometimes less stressed. Also have had patients with dementia who forgot about even the terrible sad things about their circumstances that their spouse had died, and they can convince themselves or they still believe that, they're on holidays even though they're in a nursing home. They're thinking that they might be going home soon, so they're looking forward to that. They're
Mm.
still thinking that their loved one is still alive and they're happy with that. And we don't remind them that their loved one is gone.
That's
Um,
exactly what I was going to say, Dave, is from my experience. I sense with some people, oh, if I get dementia or whatnot, it's the end, it's hell on earth, it's blah blah blah. Some of the happiest people I've seen have Lewy body, have Alzheimer's, which are not the same thing, and And they're leading great lives, and they do that for years. And they love, terrorizing the staff at long-term care homes and, asking questions that they would never ask if they were younger, and making opinions on the news that can peel paint off walls. They're living great lives. It's not the life that they were living, but you said exactly what I was just going to say. They're still they're still enjoying the life that they have at that time.
Yeah, so sometimes it's hard for us to predict for ourselves what we'd want. So we don't want to project too far in the future, especially when we're 20 years old and
Yeah.
making decisions about resuscitation.
And snowboarding.
Yeah.
Thanks, Craig.
You're welcome.
The form, the Fraser Health form that you were showing, Celine asked the name of that again.
Yeah, so it's MOST, medical orders for scope of treatment. Medical orders for scope of treatment. But if you Google most Fraser Health, most Vancouver Coastal Health, you'll see the form pop up. And your family doctor also has that in their electronic medical record. So it's actually pretty easy for us to print it out, explain things to you, have you think about things, talk it over at home. And then we can have another discussion if you want to make it official and knowing that we can return and review things annually or if any conditions change.
This is from Lucy. If a senior lives alone, which sh they should not be, and Fraser Health sends home worker and nurse to help out as long as waiting list for retirement home, any suggestions? If you can see the question in the chat there.
Yeah, we have a big problem with lack of resources, like the wait for long-term care facilities for people that need it. We don't have enough, and people are, yeah, waiting a long time, and we have limits on home support as well. So that's really tough too, because health authorities are really struggling with lack of staff, lack of funding as well. We definitely need to put more of our tax dollars into long-term care facilities and to allow people to live at home safely as long as they want to.
Yeah, it's difficult. Well, that's it. Anybody else have any other questions for Dr. Wong?
Yeah, and then Selena made a comment that most seniors she's seen in long-term care are not happy. So I think we need to see what we can do to make people happy. If
Isn't it puppies? Can't they take puppies in there?
I'm sure the directors of long-term care facilities are and all the wonderful workers in long-term care are doing their best to improve quality of life and but it can be really lonely and yeah, it's pretty challenging. If I had the money of Elon Musk, I would be putting lots of money into long-term care and like kind of ideally would be for us to really get to know every individual to see what gives their life meaning. Um, some of them don't want a lot of social interaction, but many do. Many are really starving for that too.
Right.
So there's so much we can do if we had the will and the resources to improve the quality of life of every individual, whether they're at home or in long-term care.
Right. Yeah. Thanks for your feedback, Celine. And thanks, Dr. Wong, again. This is not an easy subject. Next time will be funner. We'll talk about relationships and friends and all those good things. But this is important, and it's so I'll share that the updated information sheet, including information on MAID, will be uploaded on our website probably tomorrow. So keep your eyes open for that, and yeah, you can share it with your family and friends and. Yeah, thank you for walking us through this stuff.
Oh, Selena made a comment that she visited her mom often when she was in long-term care, and you always felt bad for other seniors that didn't have any visitors. But I'm pretty sure your mom would light up in the time and she's always looking forward for you to go there. And
Yeah,
I'm pretty sure you probably would be talking to her neighbors and trying to say a few words to lift their spirits as well. And it reminds me of our great family practice teacher at UBC in first year. He made us all go to a long-term care facility, but we had to be restricted to a wheelchair. And just so that we knew what it was like to be in a hallway in a wheelchair and not be able to walk
Wow.
around. And he always encouraged us that when you walk through a long-term care facility and in a hospital, you don't ignore the people that you see, even though they're not your patients, they're people you know, but to give eye contact, to acknowledge them, to say a kind word, and to help people when they need help. It's so easy to be rushed, but we need people to know that we see them as individuals that we care about. Um, So I think we should always be visiting long-term care facilities more often. And they really love schools and kids coming to visit and singing their songs and spending some time with them. So if I was as rich as Elon Musk, I would actually set up a program where the elderly could be mentors for the children in the community, and the children can bring their life and energy and enthusiasm and music and stories to the elderly as well because we're missing a lot of wisdom and
Oh, for sure.
talent if people are left alone in a nursing home without contact with the greater community.
Right. Our wonderful, we have a foot care nurse, Evelyn Coxon, who I also support on a monthly basis, and she's mastering the ukulele. So she goes to school, she takes classes, and then they go out and they perform. And her performances are getting more and more advanced, and they go into care homes. And she was very busy performing over Christmas, and so it's wonderful that there are people out there that do those kinds of things.
Yeah, it's nice that they went out once they mastered it rather than I wouldn't want to go in and learn violin and torture
Yeah.
people that are captive at a nursing home.
No, she has some skill now and she takes it out in community. Oh, that's great. Excellent. Well, kudos to Elaine or to Evelyn. Anyways, anything else, folks? Any chats? We're done a little bit early, but that's okay. It's a Thursday
Yeah,
night.
yeah. And Selena mentioned music is great.
Hmm.
So music is amazing. So my neighbor um, is a great musician. Um, so it's Mike, my neighbor, who was a teacher at STM, taught kids how to make electric guitars. So he actually plays in a band. So he's always going out to senior centers and long-term care facilities and playing music for them. And really, they play all of their favorites, the old classics that they enjoy, and that really connects them to positive things in the past and in the present.
Yeah,
So we should continue to look after our elders.
yeah, for sure. Thank you for your kind words, Monica. Nice to see you.
Okay, so
Are we
no,
ready?
yeah, so don't miss our next talk just in time for Valentine's Day, the positive potential of our relationships. So how uh, to make the most and make sure the people that are important to you know how much they're loved.
Hmm. So I just popped the link to that one in the chat. You have all the information and you can register right from that link. So maybe we'll see you next time.
Yeah, we'll see you in a couple weeks.
Yeah. All right. Take care. Have a great night, Dr. Wong.
Thanks, Leona. Thanks for
Don't
everything.
forget to complete our evaluation. It'll take 30 seconds. Take care. Bye.
Bye.